Intestinal atrasia and stenosis. This is a congenital defect in the intestinal continuity, one of the most common causes of the neonatal intestinal obstruction. The pyloric atrasia is a rare autosomal genetic defect in which the pyloric lumen is completely obliterated, either by the diaphragm or the complete absence of the pylorus, with loss of the bowel continuity. Non-bilous vomiting is the main presenting symptoms. Abdominal radiology shows single gas bubble or air fluid level and no distant area in the distal area in the GIT. The treatment is resuscitation, a surgical excision for the membranous atrasia or side to side gastroduodenostomy. Excision of the membranous atrasia or side to side gastroduodenostomy. So we will see single non-bilous vomiting, abdominal X-ray. We will see single gas bubble or air fluid level, and there is no distal air in the GIT. Second one is the duodenal atrasia and stenosis. They are most commonly believed to be caused by failure of the recanalization. They are usually classified according to the site of the obstruction, to the pre-ambulary and post-ambulary and peri-ambulary, the majority. It's a pre-ambulary. Associated anomalies: 40% have trisomy 21, Down syndrome. Cardiac, genitourinary, anorectal and esophageal atrasia. Diagnosis: antenatal ultrasound shows polyhydramnios, dilated stomach, and proximal duodenum. Vomiting, clear or bile stained, usually starts within hours of birth. Dehydration follow rapidly. Because of high level of atrasia, there is little or no abdominal distension. Diagnosis of the incomplete intestinal obstruction may be delayed beyond neonatal period. X-ray of the abdomen in upright position is all that is necessary to confirm the diagnosis. Large collection of the air in the distended stomach and the first portion of the duodenum leads to the double bubble appearance. So in this disease entity, the duodenal atrasia, we will see double bubble appearance. The treatment is resuscitation if is not an emergency, and surgery, diamond shaped or side to side duodenostomy, because the affected side or the excision will be the inside the duodenum. Next one is the jejunal atrasia or stenosis. Etiology: the most forward theory is a localized intrauterine vascular accident with ischemic necrosis of the sterile bowel. Type of atrasia: this is the types of atrasia. First one, type 1. The obstruction is caused by the membrane or web formed by the mucus and submucus. The dilated dilated proximal and distal collapsed bowel are in the continuity without mesenteric defects. And there's the first one. Type 2. The proximal bowel contained to the collapsed distal bowel by short fibrous cord, and the mesentery is intact in the both type 1 and 2, and the total length of small bowel is normal. Type 3A, proximal and distal bowel are disconnected. The fibrous band is absent, and V-shaped mesenteric defect of the varying size is present. The total length of the bowel is subnormal. Type 3B, apple peel or Christmas tree, consists of the proximal jejunal atrasia near the ligament of the treats. Absence of superior mesenteric A beyond the origin of the celiac branch. Large mesenteric defect with significant loss in the intestinal length is present. That's type 3A, 3B is not clear here. Okay, the type 4, there is multiple segment atrasia, combination of the type 1 and the 3, grossly shortened bowel length and high mortality. Clinical manifestation: polyhydramnios during pregnancy, bilious vomiting on the first day of life, dehydration, fever, unconjugated hyperbilirubinemia, abdominal distension. 60 to 70% of these neonates fail to pass meconium on the first day of life. Although meconium may appear normal, it is more common to find a grey plug of the mucus passed via the rectum. Signs of ischemia and peritonitis, tenderness, rigidity, edema, and erythema of the abdominal wall. The diagnosis: clinical finding plus a plain X-ray of abdomen that showed two gases filled and fluid-filled loops of a small bowel, but the remainder of the abdomen is gasless. Air fluid levels may be scanty or absent, and many may become evident only after decompression via the nasogastric tube. The management is resuscitation with IV fluid, nasogastric tube, and antibiotics. Surgery depends on the pathological finding. Resection of the proximal dilated or the hypertrophied bowel with primary end to end anastomosis, with or without tapering of the proximal bowel in the most common surgery.